Bonjour. On va passer en rythmologie et Dr. Wadih Ayoub, il va nous parler de la prise en charge de la fibrillation auriculaire en 2025.
Hi. We will talk today about atrial fibrillation. It's the most common heart rhythm disorder that we see usually worldwide. It affects millions of people worldwide, and it's still, until now, poorly managed, even in Lebanon or other places in the world too. So I will go an overview over the whole disease and how we treat it medically and how we go to the process to ablation thing. So first, in classification of atrial fibrillation, we talk about atrial fibrillation that happened very shortly. We call it first diagnosed AFib. Then we move to persistent atrial fibrillation, which terminate within 7 days. Then we have the persistent atrial fibrillation when the AFib will be consistent for more than 12 months. And then we go finally to the permanent atrial fibrillation, which with the patient will be in always atrial fibrillation, and the probability of restoring the normal sinus rhythm is very rare usually. Another type of atrial fibrillation, it will be the valvular atrial fibrillation. People with rheumatic mitral stenosis, mechanical, prostatic heart valve, or mitral valve repair. Those are the category of atrial fibrillation that we're going to talk about it very fast. So prognosis and mechanism. The major issue of atrial fibrillation, what we see lately, is 1/3 of people will get cryptogenic stroke will occur from atrial fibrillation. Due to many studies we did show this. So now most of the people who get strokes, they are screened for atrial fibrillation, usually. Risk of venous thromboembolism usually is very high during the first 6 months. And then AFib usually involved in all kinds of disease, in end-stage renal disease, in patients with chronic kidney failure, increased risk of MI, risk of congestive heart failure, and of sudden cardiac death. So what the purpose of this is to ensure that atrial fibrillation is very widely overlooked, and it's involved a huge role in multiple diseases that we face every day in our practice. And they usually exacerbate all of those diseases, which could end into high mortality with patients. So we have to address this and treat as much as we can. Atrial fibrillation, how people will present in clinic, they will complain of palpitation, fatigue, diminished quality of life, and reduced exercise tolerance. And I want to point something very important here with this thing is tachy-mediated cardiomyopathy. We've seen other patients here, especially in Lebanon and other countries where we don't treat AFib. Other patients, they come already in permanent atrial fibrillation, and the rate is not controlled, and they develop cardiomyopathy, and we end up placing a pacemaker and ablation in the AV node. Usually, those patients in the United States or in Germany, even in Europe, they see this patient much less and less because atrial fibrillation are targeted and treated way before that. So it's very important what we see mainly here in Lebanon right now. So if we can treat this, people don't end up having defibrillators and ablation of the nodes. What are the main risk factors for atrial fibrillation? I'll go very fast over it. Main factors we see every day with hypertension, obesity, sleep apnea, hyperthyroidism, and excessive alcohol and drug use. This is a picture will depict the atrial fibrillation and what's mostly coming from. If we see here, this is the left atrium, the pulmonary veins. So 94 to 95% of the atrial fibrillation originates from the 4 pulmonary veins from the left atrium. We will go through it shortly. Rate versus rhythm control. Okay. This is important. A lot of people here usually go for rhythm control, for rate control if they have atrial fibrillation. And they think if they lower the rate, people will get better. I mean, rate control is a good option for AFib, but we should aim always for rhythm control. So restore sinus rhythm in the patient. It will improve his risk for most other disease and will help him a lot. So we should aim always for rhythm management, mainly more than rate management. Okay. Any management that we do for atrial fibrillation with rate control or with rhythm control, it will always prevent the patient and prevent deterioration of left ventricle function. So, of course, I would say the management and improvement of any patient, any disease, even renal disease or cardiac disease, we should aim always to rhythmize the patient. So cardioversion or a high dose of antiarrhythmicum or even with ablation. We'll talk about it in a little bit. Antiarrhythmic drug, I will go fast over it. The most effective drug will be amiodarone, which will be very prescribed in Lebanon, but most of the patients don't need so much and so high medication. Propafenone, 37%, but it's very effective with people, young patients, or people with no other issues, no other disease, no other cardiac disease. I mean, like ritmolol in Lebanon. Sotalol is also effective as propafenone. And we don't have those medications in Lebanon, and dofilab, dronedarone, Multaq, we don't prescribe it anymore, it's old medication. So main issue in this medication, mostly widely in Lebanon, will be used amiodarone. It's a very effective drug, but it's very potent, and it's very dangerous and has a lot of side effects comparable to other antiarrhythmicum. One other issue is with the sotalol patient. I've seen patient here in Lebanon will get sotalol without monitoring. Any patient will put on sotalol, there has to be on regular EKG every day and compare with the QT prolongation, because this could end up really bad. So mainly when I've seen Lebanon, they all go with amiodarone. It works, but it has a lot of side effects. Surgical maze, we have two surgeons here. I mean, I'll start with it. It's an old procedure aimed to compartmentalize the atria to prevent propagation of multiple babies. So this procedure, some surgeons do it, some surgeons don't do it. My aim in this is to, if you have a patient with mitral valve problems, valvular AFib, and you send him for operation, it's worth it to do the procedure. It might help. It has a lot of complication usually, but it's worth doing it. This patient is going to the OR anyway. Some surgeons love it, some don't. And now we go to the most important part of this with catheter ablation. This is a very important slide now from the 2024 guidelines. Catheter ablation is removed now to the class 1A indication. A couple of years ago, AFib ablation, the catheter ablation was like 2A or 2B indication, but now it's becoming more effective. We have more technology. It's safer than used to be. And it's by far more effective than any medication that we give for patient. Okay, I'm gonna go very fast here for AP base of ablation. What we do in ablation is AFib ablation requires a trigger from the atrium, and you have to find a substrate. So the goal of AFib ablation is to prevent AFib by eliminating the trigger either or altering the arrhythmogenic substrate. So this is what I mean in this thing. So this is the main thing what we do in the atrial fibrillation. We have to eliminate all those areas. This is the pulmonary vein, left superior, left inferior, right superior, right inferior. This is account to almost most of the 94-95% of the atrial fibrillation. So the goal of any EP, any ablation is to eliminate all those substrates. This is a picture. I will go over the old technology that we use since 2008 about atrial fibrillation. So we start with radiofrequency ablation, the first to come. If we see here, we have to go. This is a mapping catheter. We map all those substrates, and we see them as intracardiac electrograms. And then we go with the ablation catheters, radiofrequency energy point by point all around the area. And then we have to map with this mapping catheter, and we see if the signal is gone and we don't have a conduction from the pulmonary vein to the atrium. Then later in 2012 comes the other technology with the cryoballoon ablation. It's the same thing, but you go with a small catheter, and it's a balloon would be inflated on the os of the pulmonary veins, and we'll talk about it in a little bit more. Okay, so end point of any ablation that we do is, end point of any ablation is we have to ensure there's no more substrate coming from the pulmonary vein to the atrium. So in other words, either you pace from the atrium and see if there's conduction, or you don't. This is the end point. If this is successful, then you've done your job. More, if not, then you have to ablate more to eliminate all the substrate. I will go. This is probably too. Okay, this is important. So I will go now about radiofrequency energy. In 2014, The radio frequency energy came with a catheter, what we call pressure sensor catheter. So that means when we put the catheter on the tissue, it will tell you how much pressure you have on the atrium, on the area. And then you can manage the amount of energy given to be more effective. So that came out in 2014. So we'd still talking about the very conventional AFib. And then usually, okay, so cryoballoon ablation will just show you before. I have a picture of balloon here. This is so it's a liquid nitrous oxide delivered under pressure through the catheter to the tip. I will show a picture better. This is better also. This is a cryoballoon ablation. So we have the balloon. You have to occlude the pulmonary vein, inflate the balloon, and you have something we call the achieve here. This is a catheter with almost like 90 poles. And you control the signal here. When you inflate the balloon, you inject contrast here, and you ensure there's no leakage anywhere, okay? And then you give the energy. Usually first we start doing it in 2012, 2014, and we go like minus 60, minus 70. Later now we do it like only 2 minutes, like minus 40, it should be okay, and that's 1 minute. Before that we do it 2 minutes in each vein. You inflate and deflate the balloon, and you have to ensure there's no more signal here. The best thing is to put this achieve close somewhere around here, and you see the signal going away. So this means that you have an exit block, we call it. You have eliminated the trigger that caused the AFib from the pulmonary vein. Those balloons come in two sizes. Usually we use the regular size. They're a small one. You don't want it inside the vein too much. This is a picture of free picture. You see the balloon, and you inject contrast, and you have the achieve here. Once the balloon is inflated, you go with the energy minus 60, minus 70, and then you see it like after 10, 15 minutes that there's no more signals coming inside. Then you have clear, ablated or isolated the vein. If you still signal, you have to go one more time or 2 more times. Main issue with this technology since 2014, it's opened the door to what we call right now, I'm gonna come to it, the single shot ablation. So this point by point, it take us like hours and hours. With the cryoballoon ablation, time is like was limited to like 1 hour, 1 hour and a half or less. And the results were perfect, close to perfect. So this is a very important study. I will go over studies very fast. It's called the Fire on Ice study. Even with this study, came out before the pressure sensor catheter. So this study compared the radiofrequency conventional ablation with the cryoballoon ablation. And it did show non-inferiority to the one-shot ablation with the balloon. So it we did show a great result. Okay, this is a map for the we call 3D map of the left atrium. So this is the left side, and this is the right side. Okay, so in red you see that the veins are isolated. This is the posterior wall of the left atrium. It's still intact. So in every ablation, this is the endpoint what we want to see. We don't want to see any signal coming from here to here. So either we get it with point by point with other frequencies, the old technology, or we go with the balloon ablation. But what I mean is if I bring any patient, like a healthy patient, and I just put a catheter here, and we just pace the heart, I can induce atrial fibrillation. The atrial fibrillation will last like 6 seconds, 7 seconds, 1 minute, and then will stop. The thing is that they don't have substrate for atrial fibrillation. So my goal in any ablation with someone who have AFib is to put a catheter here and to induce AFib, and we don't have AFib anymore. So this means this area is not connected anymore, and the posterior wall is not active anymore, usually. Okay, now I'm going to go very fast. Couple of studies which will ensure that AFib ablation helps a lot of patients. There's a huge study called the Cabana study, which was made in the start in 2009, and it was comparing the people who endpoint in it. Ablation was no worse than medical management. This means any patient will get an ablation, he still got a good result, much better result than just putting on medical treatment. It was very, for symptomatic patient, it was first-line treatment, and it was much better option for people less than 65, and with patients with congestive heart failure. For patients above 75, it did not show great I think. It's another study called the Castle AFib study. We did show that people who got AFib ablation, it did show some improvement. They're symptomatic, and it did show superiority to rhythm management. Another study called camera MRI study did show that AFib ablation did improve the left ventricular systolic dysfunction, and a lot of improvement in patients. I just have a patient in CMC. We done an ablation like a year ago, and EF improved from almost 35%. Now he's almost 55%, just for AFib. He's been having AFib on and on all the time. So ablation is far more superior than any medical measurement that we give, usually. The camera MRI study was also involved with MRI, and they compared the whole fibrosis. We're not going to go too much into this. The STOP AFib ablation was a great study, comparable cryoballoon ablation with drug management. If you see, it's by far more effective than any medical treatment we do. Okay, now another issue is the paroxysmal atrial fibrillation versus the persistent atrial fibrillation. The dilemma with the persistent atrial fibrillation, when people are going untreated for many, many weeks and many months, and the left atrium will be very stretched, and the goal of restoring sinus rhythm is going to be very hard. So those people, they can profit from ablation, but still you have to do more work than just the pulmonary veins. You have to go all over the wall of the left atrium. And paroxysmal atrial fibrillation, people on and off, those are the best candidates that can profit from that. Okay, this is a picture of a 3D mapping that we do usually. So if we see this is a picture of paroxysmal atrial fibrillation, we isolated the veins, and usually they should be okay. And the area of the left atrium is still very healthy. This is an example of someone who have a persistent atrial fibrillation, and then you do the veins, and you have to do all over the wall and do lines. Usually, they still have AFib, and they create atrial tachycardia later on. And I remember in Washington, we used to do something called a surgeon that would help me with this. We call a hybrid ablation. So we do ablation from inside the vein, and they go and they do it from outside. And this is how it looks like as we map the atrium. The problem is after a couple of months, they still have AFib. So better to find those patients in the paroxysmal area when they still have an AFib and on and off, not when they go into the permanent atrial fibrillation. Then the help is going to be very limited. Complication of any atrial fibrillation. So usually the complication might scare some of the people, but it's mainly a complication that happens in any interventional cardiology practice. It could lead to tamponade, perforation, all those things happen. Some complications were in literature are still very rare. One of them is this pericardioesophageal fistula. Usually when this thing happened only with radiofrequency energy ablation. Those complication happened before the 2014, before we created the pressure sensor catheter. What we usually do, to put, some people, some don't do it, they put in the esophagus, they put a temperature probe. And when they ablate on the left side of the atrium and they see the temperature is rising up, we stop ablation and move to the other side. Before 2012, we didn't have a pressure sensor, so we didn't know how much the catheter is touching the tissue and how much energy are we giving to be effective. With the presence of the pressure sensor catheter in 2014, we limit the energy we do and we control the temperature, and those complications are less and less happening. But it did happen in the literature. That's a CT of it, if you see it. This is another complication. This is what happened in the radiofrequency conventional atrial fibrillation ablation. Is the pulmonary vein stenosis. This is left superior pulmonary vein. It's stenotic here. So what had happened here is when someone is ablating and he moved the catheter all the way inside the vein. Now the surgeon can help me more with this. When they ablate inside the vein, after a while the vein stenotic and people come with bleeding and stuff. You've seen probably this, yeah. So this is a patient. We did put a stent here, but I mean, after a while they develop some pattern, and after a while we send them to surgery, and they probably take a whole load.
We still have 1 minute, please. 1 minute. We still have 1 minute.
A moment, okay, I'm very good. Okay, very sorry. Very fine. Visophrenic nerve injury. This is from the cryoballoon ablation. This when we ablate, we have to pace the phrenic nerve so it doesn't injure. And now I'm going to go to the last slides. The new technology, the pulse field ablation for atrial fibrillation. This is a novel, largely non-thermal technology. It is much better than the other technology with far more time, no need for contrast, and the collateral damage for tissues around the area is very, very minimal. The first parapulse that we have here approved, this was from Medtronic, and what we have here in Lebanon is from Boston Scientific. This is a picture from our lab in CMC. This is how it looks like. This is the wire inside the left superior pulmonary vein, and you do like 2 seconds, and then you move those flyers, and it takes 2.5 seconds, 3-4 times, and the whole area is ablated. It's very promising. It's very with zero complication, with zero stuff that we used to see before in the other technologies. This is an advantage study. It just came out to show the efficacy of this procedure and the safety of it, and that's about it. So risk factor modification will have to control hypertension, sleep apnea, obesity, and that's a summary. I don't have any time anymore. So what I mean is just we have to stratify those patients by much faster, and we treat them, and this thing could lead to a lot of health problems. That's it. Thank you. I don't know. Thank you. Thank you.